with that, I would like to go ahead and get started with our first question. And I know this has been the first question for our previous 2 webinars, but I think it's definitely the most important question and the most frequently asked question. I have Pheo Para, and this person specifically is asking, I have metastatic pheochromocytoma to the bones and everywhere else. Am I more susceptible to getting COVID-19 and to getting very sick from COVID-19? And maybe you can kind of address it in a broader sense as far as people maybe who just have a genetic mutation and don't have any tumors, as well as people who have metastatic.
Well, first, thank you for giving me the opportunity to join the discussion today, and I appreciate those of you who have come in with questions. It's really always a pleasure to participate in this group's activities. So starting with individuals who have a germline mutation, so for instance, an SDHB mutation, they have one copy that has the mutation and the second copy is normal functioning. In general, in the absence of a tumor, we presume those individuals are normal, are otherwise normal. They're not at increased risk for other types of illness. Like for instance, one might think if you have a mitochondrial mutation, you might be at increased risk for having muscle pains and muscle damage but we don't see that clinically. Some have raised the question about whether or not there can be some immune dysfunction in heterozygous individuals, but at this point, I think the party line is we don't really have convincing evidence of the case. So our SDHB, so-called pre-symptomatic individuals, are not at increased risk. The second category of people would be people with tumors and disease but are not undergoing systemic therapy, but they have high catecholamine levels. I think that group is the hardest group to answer the question. I think in general, individuals with comorbidities are showing up with more severe illness, but in and of itself, is high catecholamine levels and a tumor sufficient to fall into that category? I don't think I have the answer to that question. So I would say I'll take a pass and say probably not, but we don't know. And then the other category of individuals who are receiving systemic treatment of some kind and have, say, metastatic disease, I think it's likely that those individuals are at increased risk for complications of the disease. Now, for 2 reasons. One, it could be that they have a suppressed immune system as a result of the treatment. And 2, because they could be predisposed to a catecholaminergic surge in response to illness. So when your oxygen levels go down, there tends to be an adrenergic drive that would be excessive in the case of underlying pheochromocytoma, paraganglioma. So that same idea could relate to the person who has a pheo that hasn't been removed yet and isn't known to be metastatic. So I'm sort of hedging a little bit there, but that's in the absence of knowledge. I'm not sure what else to say.
Thanks. And actually, your hedging reminds me of our disclaimer, which this information on this webinar is for educational purposes only and should not substitute the advice provided by your medical team who knows about your medical history and your current situation. And there's much to learn about COVID-19 and specifically how it relates to Pheo Para. So Dr. Annis provides educated guess based on his current assumptions based on COVID-19. I also forgot to mention that you can submit your questions live using the chat function or the Q&A function, and we're happy to answer those as well. For those of you joining late, again, welcome. My name is Stephanie Alband, and I'm the Executive Director of Pheo Para Alliance here with Dr. Justin Annis of Stanford. And I also didn't have my script in front of me because I wasn't planning on moderating, so he's got plenty of experience to answer your questions, and he's on our medical advisory board as well. Moving on to some of these other questions, can you talk a little bit, a lot of our patients are adrenal insufficient. Can you talk a little bit about if they do get COVID-19, how that might relate to their adrenal insufficiency? And this person had a specific question about, are there medications to carry for an adrenal event?
So I think most of our patients who are adrenal insufficient have been living with this for a while and are been told over and over again, how to respond to illness. This one, COVID in particular, the unique feature of this is that people seem to be less aware of the severity of the illness than it sort of seems to sneak up on people. So I think the unique aspect here is, well, first is always be in communication with your endocrinologist or whomever is managing your adrenal replacement. You want to be part of a team, and you don't want to be left alone to be making your own decisions. The second thing is I would be very quick to use rescue therapy. The downside of it is probably not sufficient for you if you're uncertain about what to do, whether to do it or not. I would err on the side of using the additional therapy. The third thing is that I would make sure you check your reserves if you haven't recently, to make sure they're up to date and that you have them available at least for a week-long period or so. So again, that should be done in communication with your treating physician. Aside from that, there's not specific dose adjustments that I would say that's unique to this disorder. It kind of depends upon who you are, what the degree of insufficiency is. Is this, partial replacement? Is this full replacement? So I'm going to stay away from numbers.
Thank you. I know that, keeping our immunity up is really important during this time. Can you just talk a little, this person had a very specific question. It looks like they're still getting some imaging done. And do any of the contrasts used for imaging reduce immunity to your knowledge?
No, to my knowledge, I don't think there's any known immune suppressive effect of contrast agents that are used. I think try to go through all the different modalities, but there's no contraindication under any circumstance that says, oh yeah, this, an MRI contrast is likely to cause immune suppression. No, there's nothing known like that. Even our
Hi.
So sorry, I thought it was 7, not 6.
Oh, that's all right. This is live TV, people.
So sorry.
That's all right. Welcome, Robert. Robert Spokey is on our board of directors, and he's our moderator today. I was stepping in for him while he gets settled. Robert, I did our introductions, and I've gone through some of these questions, and I'll provide Dr. Annis another question while we get settled in. So can you just talk a little bit about how your clinics and surgeries have changed? I know we talked a little bit before we started broadcasting about, regulations starting to ease up, and what the state of your clinic and surgeries was before, and has it changed at all? And are there plans that you know of in the future that are changing?
Yeah, so the first, of course, to start with the disclaimer that this disease is being handled very differently across different geographic areas. So my answer is really specific to our experience at Stanford, and in this particular area of California, because even Southern California has somewhat different rules. So the biggest change is that we're now 100% or virtually 100% video visits. That's for our endocrine and medicine genetics visits. Our surgical visits are occasionally in person. Even in general, our anesthesia preoperative visits have now moved to telehealth or video visits. So for routine care, almost everything has gone to video. Our laboratory testing initially was almost put on hold to stop, and now it has somewhat resumed. We have a slightly lower threshold for laboratory testing. So our patients who are otherwise healthy and don't have severe comorbidities, who aren't older age or at risk, we're going ahead with some of our screening. Again, that's going to be different from region to region, but our infection rate right now is pretty low. So we're thinking that those labs are okay for the people that we think need them. For our surgery, that Pheo Para removal has been generally postponed or at least looked at, is it necessary or not early on. At this point, we're seeing that the delay is likely to be months to a year long, and so we're progressing with our with our surgeries that aren't necessarily urgent, but are clearly indicated for curative treatment. All along, patients who had emergent reason for his treatment were undergoing treatment. We have not fully resumed some of our nuclear medicine treatments that we're using sparingly. So if someone was on Lutathera therapy, for instance, or Zedra, we're being very cautious about restarting those because of the immune consequences and the idea that we're not sure exactly which is the right treatment schedule or the best treatment schedule. So I don't have particular answers to someone who's in that position.
Doctor, I don't know if you went over this, but last time, Dr. Annis, last time when we started, there's a group of people that are considered to be at risk, those with asthma, older people. If you have a Pheo or a Para, would you be one of those people that would be considered at risk? If you more at risk if you get the virus, and if so, why? Because it seems that it may affect your lungs, it may not affect your lungs, but are you more at risk just because you have a Pheo or a Para?
Yeah, so we touched on that early on, but just to recap in brief, we don't consider Para-Pheo a uniquely immune suppressed state on its own. Associated therapies could put you in a suppressed condition, which might increase your likelihood of having more severe disease. The risk factors that have come out are primarily diabetes, obesity, other end organ disease. So you're right, and it's of what we know, we can't say specifically anything about Para-Pheo as a risk. My concern continues to be that people with adrenergic producing tumors could be at risk for labile unstable blood pressure as a result of the stress of illness. So even if you don't have lung disease per se, there could be a secondary ramification of having a high adrenergic state. Yeah. So that's where I would go with that. Unless if you have underlying lung disease or the disease is in your chest, that we would be concerned there too.
I'm going to hop off and help Robert on the back end with some questions. And Robert, I was also mentioning that there was a number of questions from yesterday's surgery webinar that weren't able to be answered. And so we'll sprinkle those in too as well to you, Robert.
Can you send me the link as well to the...
Yeah, sure, no problem. I will send you the link. And one more question that I will provide to you, Dr. Annis. How do you see bone mets behave once a primary abdominal tumor has been removed? The non-COVID question there.
Yeah. So this is usually very, very patient specific. We know that in tumors in general, disease, the tumor starts in one location and then can spread to others and has metastatic. But each of those different pockets of disease can behave very differently. So you can have one tumor in the bone that doesn't grow at all and then one somewhere else that does. So it's very hard to predict exactly what kind of growth you'll have of a particular lesion. Something we do in other cancers is to take biopsies of these different metastatic sites to get an understanding of what's the proliferation rate, what do the cells look like, how are they likely to behave. In this particular disease, we don't do that because of the risks generally associated with biopsy. The question may relate also to a person who has sort of an in-depth understanding of other types of disease. Sometimes in melanoma in particular, there's this very unique phenomenon where if you remove the primary tumor, it seems to accelerate the growth of smaller seeded tumors. In general, we have not observed that same phenomenon in Para-Pheo. So I think in those tumors, there's probably something being made by the primary tumor as a hormone that suppresses the growth of those smaller metastases. We are not aware of such a case, generally speaking, in Para-Pheo. So I'm not sure exactly where the questioner was going with their question, and it can be asked in a lot of different ways.
Yeah, thank you for just addressing it. We get a lot of questions that are, you could interpret a number of different ways, but covering all the bases like that is helpful. Yeah. I'm going to sign off, Robert, and hand it over to you.
Okay. Very good. And again, I apologize.
No,
And,
thanks for joining.
Yeah, and do you know what's even worse is that my son is now part of the webinar for the first time.
Good showing.
He was texting me too, and I just, okay. I'm not sure which question we had, but if you know a patient has a genetic mutation such as SDHB, and there are different approaches to surgery than would normally be taken with someone who doesn't have a genetic mutation.
Okay.
Are there different approaches to surgery? I guess that was one of the questions that came up the last time. I guess they didn't have time for it. I'm not sure. I wasn't with that one.
Yeah. Well, I imagine this could be asked by an individual who has a sort of very specific scenario in their mind. I would say we generally, when we approach SDHB-related disease, we approach it with this understanding that for unexplained reasons, and so far, we seem to see a higher metastatic rate in SDHB-related disease. So whether or not that's number is 30% risk or 40, we're not sure exactly what it is, but there's this understanding that we should be a little bit more aggressive. So yeah, there are a variety of situations where we would be more aggressive with B than with something else. For instance, in neck paragangliomas, we probably pull the trigger earlier on removal rather than watchful waiting. In adrenal disease, we tend to do a full adrenal resection rather than a partial. So yes, the underlying germline condition does drive decision-making in various clinical scenarios.
Okay. Post-operational, how long will one have symptoms? I'm 3 months post-op, still having chest pain, blood pressure issues, shaking, severe anxiety, palpitations, etc.
Yeah. So this is a really interesting / tricky question to answer. So generally, we should see resolution of catecholamines, metanephrines, within a month's time. That accounts for some amount of recovery from surgery and so forth. When you look at what percentage of our patients actually recover to normal blood pressure, it's not 100%. So many people will resolve their metanephrine levels, but not their blood pressure changes. And now that could be for a variety of reasons. One is because they have underlying essential hypertension or blood pressure. The second reason is because they might have had long-standing disease, and then they've had changes in the way their vasculature works, and then they just don't know how to relax the same way. Now, this particular patient is asking about more of a surge anxiety related symptoms. So meaning things that are associated with heart rate, blood pressure, and what were the other symptoms?
It was blood pressure issues, shaking, severe anxiety, palpitations, chest pains.
Yeah. So the first approach, so those should resolve is really the bottom line. If you remove, if the metanephrines have normalized and you can show that you're not getting spikes in those episodes, that really should have changed. Now, that doesn't mean that those events aren't happening. It just means that the primary driver is less likely to be catecholaminergic surge. So in those cases, one of the first things we do is see whether or not it's responsive to alpha into alpha antagonists, and make sure that there's not something residual that we're just not picking up biochemically. And we also look at other types of causes. I think this can be a traumatic experience, and there can be residual effects of having long-standing disease, and those have to be looked into, as well as alternative explanations.
Okay.
Yeah. So without getting direct feedback from the questioner, it's hard to know whether or not I've hit home or not. So if someone has that button, they should feel free to follow up or something to let us know.
Okay. Well, what does, I'm going to pronounce this wrong, octreotide do? Okay, that's the shot, correct? Right. I understand it's a hormone and not a chemical. Does it shrink paragangliomas?
Yeah. So a lot of the understanding of how to use octreotide other than imaging. So I think this person is asking therapeutically about it, how do we use it? a lot of the data really comes from neuroendocrine tumors. And so we're sort of borrowing a little bit there and applying it to Pheos. One of the main benefits of octreotide is that it generally reduces the secretory, the activity of endocrine cells to release their hormones. So it can help by reducing the amount of secretion. For instance, your chromogranin A level is likely to go down as an indicator of less secretion hormone. The question of what's its therapeutic benefit in para-Pheo remains a little bit open. Generally, our hope and our expectation when we use it is that as we get disease stability, that we slow growth. You're unlikely, other than case reports, you're unlikely to see shrinkage beyond 20%. Which is often used as a cutoff for a partial response, and very no one should expect to get complete response, which is getting rid of the disease. But there can be slowing. And yeah, I think something that's interesting and related is that in MEN1, for instance, there's been some suggestion that we can use octreotide early on to slow the growth of tumors that we're just watching. So whether or not that becomes relevant to us in the SDH or para-Pheo world is a good question.
Okay. This is actually a very good question, and it's virus related. My regular imaging was delayed because of the virus. This makes me nervous. Can you please talk about when or if you are suggesting people have regular scans during this time?
Yeah, so a lot of that depends upon sorry, I might get someone wandering into my background. I'm not sure, I heard a door open. A lot of that could depend upon the underlying circumstance. So is this a biochemically negative, potentially at-risk individual who's just getting routine screening and the screening was just done a year ago? In that circumstance, I would have very little concern about delaying imaging. If it's a person who we're watching and they know that they have growth near their spinal cord or something of that nature, then of course we want to get imaging done. In general, I would say that our interval right now, so let's take SDHB patients who have a germline mutation but no known disease. There are differences in recommendations that go from everywhere from annual screening to screening every few years, but only of the neck region. So the idea that waiting a year or so in that circumstance is probably fine. Again, each individual is unique and it depends on how long it's been since the last screen. I don't know if I got to the question well enough there.
I think that you did. What about if you're getting some sort of treatment like HIGB or some other treatments? Obviously, it depends upon the doctor, but do you consider that to be essential or non-essential?
There are a variety of ways of following treatment response. Generally, we commit to a course of treatment, and there's interval imaging just to make sure we're seeing response. It's hard to say that's non-essential, but I think we tend to want more information than we actually probably need. So most of the time, we can use our biochemical or surrogate markers. I think without getting myself into trouble, it's very hard because I think there are circumstances where we really want to get imaging done, and there's others where we feel like we can postpone it. I'd say as an overall rule, these tumors are moving generally pretty slowly, so that a 3, 6, 9 month, 1 year long delay typically is not going to impact outcome.
Right, and I'm sure that makes people feel a little bit better. I have a Glomus vagal tumor, V-A-G-A-L-E tumor. Okay. I'm worried when doctors tell me it's inoperable. Can you explain the risk of leaving it versus surgery?
Yeah. So this is really one of the psychologically most challenging things to do, which is to be told that you have a tumor and then to be told we're doing nothing about it. And I can very much empathize with patients who are going through this. The issue in this particular surgery is typically neurologic damage. Whoever, each individual surgery is different, so you have to see the tumor. So again, I can't speak to your specific tumor, but if surgeons are saying they don't want to touch it, it's because they're saying you're going to have a neurologic deficit. You're going to have a problem if we do this surgery. Now, if we look at the natural course of what happens, again, this is where the genetics plays in, but let's say this is not an SDHB or there's no evidence of spread. We know that most of these individuals and most of these tumors grow to a certain size and then really slowly or stop their growth. Most of them can be watched. That's not, of course, universal. So you have to follow the changes and make sure that there's nothing going on. So the other option is that you can do local treatments, targeted treatments. You can use radiation therapy, which people can feel is safer in some circumstances. So I think the general are more and more we're watching these tumors, and we're waiting to see. We're not going to do something which has almost 100% certainty of causing problems unless we have to. So my guess is that this particular team is saying, let's see this tumor just sit there, cause no problems. And then if it starts to change, if it becomes something that we have to deal with, we'll take it on then. That would be my guess.
Okay. A general question. I was recently diagnosed. I am not sure that my doctor has any or enough Pheo Para experience. Is there some tips on how to find a doctor with Pheo Para experience?
Yeah. So I think one way is to reach out to the Alliance and ask them. And then oftentimes in those cases, you guys or various people will contact us or or a doctor in the region, and we'll know someone in the area. That's usually pretty effective. And I know the Alliance is also working on their doctor finder.
Exactly. I was going to mention that.
There'll be a more streamlined resource soon. But I think asking people in the field, and generally we know people around the country who are really focused on this as their primary interest.
And I see that Dr. Pochak is on, although I can't see him nor hear him. But Dr. Pochak with NIH is usually a pretty good resource.
I think Stephanie will be able to add him on.
Yeah, I know he's here, but I'm not sure. Okay. How about those people that have the mutation but don't have any symptoms? Are they also at risk for the coronavirus?
Yep. So this is one. This is one that we covered when you were out.
I'm sorry. Okay. I'm looking for the next question here. So that was one of mine. Actually, I had. Is there any medication to carry for an adrenal event?
So we also talked about this. That was the steroid replacement.
Okay. I'm sorry. Okay, let me.
That's okay. This is the challenge.
Okay. Okay. Does the removal of all of your lymph nodes cause difficulties in movement after surgery?
Yeah. So this again comes down to what region the surgery was done, what anatomic region. Generally, lymph node dissection and exploration has its costs. And those are related. One is related to lymph drainage. So there can be predisposition to swelling and discomfort in that area. The second is most lymph node dissection will trigger a healing response or a fibrotic response. And that can cause different types of adhesions so that the tissues stick together. They don't slide as smoothly as they would have before surgery. That can cause different types of discomfort. Sometimes even in the abdomen, the adhesions become so severe that it requires its own surgery, which is to break those adhesions up and allow the gut to have its motility back. So the unfortunate answer to the question is that generally lymph node dissection does have its effects after the surgery. Some people are fine, but yeah, it's not unusual to have discomfort, phantom type feeling, swelling, other types of consequences.
Did you also talk about improving the immune system? Ways to improve the immune system if you have a tumor or anything. Did you address that?
I haven't.
Okay.
I'm not aware of any particular interventions that we know of that reliably boost the immune system. I mean, you could ask my wife and she'll tell you that vitamin C is great for her, but the medical community hasn't shown that to be the case at this point. So as far as we know, it's a good sales pitch, but I don't know of any demonstrated immune enhancer.
Okay, fair enough. Could some of the Krebs cycle mutation offer us some protections against getting the coronavirus?
That's an interesting question. Most of your cells are what we would say are heterozygous, where they have one normal copy, one broken copy. As far as we know, is this an SDH specific question? Actually, it may not have been. Did I just read that into it?
I'm sorry, say it again.
Oh, they said Krebs cycle genes. That was so yeah. So it was an SDH, less likely
right.
One of the MDH or IDH. So as far as we know, the mitochondrial function of each individual cell is very close to normal, even though you only have one copy. That's primarily because the way the cell is counting, is there enough SDH around, is at the protein and function level. It's not at the DNA gene level. So we think generally people who have one mutation, one normal copy, they're functioning at a normal level. Now the idea is could there be a protective effect? I don't know the answer to that. In theory, what we actually have seen with aging, and this is with normal aging, which is that if you go into, let's say, normal people, and you take a skin biopsy, and you look for succinate dehydrogenase in the normal skin, there's actually a number of cells there, for whatever reason, have lost their copies of SDH. So is that more frequent in someone who has an underlying germline mutation, meaning that they were born with one copy broken? I don't know. Could that have an advantage at some level? We don't know. But in theory, the question seems unusual, but it's actually an interesting question to think about. Unfortunately, I don't have an answer for it. It's theoretically possible.
My PRRT treatment was delayed due to the coronavirus. How long can you delay with it still working?
So we don't have an answer to that question. We know that there are people, when they did the analysis on treatment group, there were people who missed treatments for various reasons. We don't know if those individuals benefited or did worse as a result of changing the interval of time. I think as far as we know, the doses, the efficacy is not based upon an accumulative response, meaning that they build up levels over a short period of time. So the answer to the question is we don't know the answer, but there's no reason to think that delaying, skipping a cycle, waiting, should have an untoward effect. You just continue where you left off. Again,
I'm sorry, I didn't mean to interrupt you.
No, I think again it comes down to what's the doubling time for the tumor size, and it's quite a long period of time.
Okay. Somebody wrote that they heard that the blood pressure medications are a bad mix with the coronavirus, and the Pheo Para patients rely on these to control their catecholamine releases.
Yeah.
What are your thoughts? Is there a mix there that's not going to work?
So I think this question may relate to the idea that the virus uses the angiotensin II receptor. So that's a protein that's on the surface of cells. That's how it sort of locks onto the cell and gets into the cell. And there's been a concern that using ACE angiotensin converting enzyme inhibitors or angiotensin receptor blockers, ARBs, could increase your risk for complications of COVID because it affects the angiotensin 2 receptor levels in the body. This is not something that's broadly true as far as we know of antihypertensives. And the American Heart Association guidelines currently are not to alter treatment, even for those people on ARBs or ACE inhibitors. So I would say that we haven't looked necessarily at secondary effects of alpha blockade, but there's no reason to think that it would be any worse than ARBs. And those have so far are thought to be okay.
There is Dr. Pochak.
Oh, yeah, there we go.
Yeah, I'm here.
Hi, Dr. Pochak.
Fighting with the system for approximately 40 minutes.
I'm sorry, Dr. Pochak.
But Justin did extremely good job. So
hopefully,
just waiting for you, trying to fill the time.
So I'm very sorry, but this is what is happening, and I'm using my own personal computer because even my computer here at work is somehow not working properly.
Okay. And for those of you that are not familiar with Dr. Pochak, he's a board-certified endocrinologist and an internationally recognized expert in the diagnosis and treatment of neuroendocrine tumors, especially Pheo Para cytomas and paragangliomas. He is the senior investigator in the section on medical neuroendocrinology at NIH. He founded the International Symposium on pheochromocytomas and paragangliomas, and has authorized hundreds of scientific peer-reviewed articles, book chapters, and books. And in full disclosure, he is my doctor and my son's doctor and my daughter's doctor. Thank you, Dr. Pochak, for coming in. I see a question here that I cannot overlook. I have metastatic para. Can I have 2 to 3 glasses of wine per week? I personally think you have to have 2 or 3 glasses of wine per week. So I have no problems with that. That's fine.
I'm not sure. It depends what kind of glasses. That can be a risky glass, and that would be a little bit complicated. But I wanted to say that patients with pheochromocytoma paraganglioma must be very careful if they are drinking, especially wine, and especially red wine, because release catecholamines, and the release of catecholamines can be dramatic. And so those that they have a problem with blood pressure, heart rate, they are on antihypertensive medication, and despite of antihypertensive medication, they still have a problems. They have to be really very careful what they are drinking. And as I said, especially wine. So I would be careful here. Even I understand what you said, 3 glasses a week, which would be approximately 1 glass every other day. But really, it depends how much wine they will have, and it depends. Everybody is different. So some are doing very well, and some they may not do well. Even they will have a half of, let's say, regular glass.
Okay, so are you suggesting something stronger?
I am definitely suggesting to avoid wine, at least, for my patients. And it's written in many articles, actually, that patients who have a pheochromocytoma and have problems with catecholamine excess-related hypertension or cardiac problems, let's say the tachycardia, the heart is beating too fast, they should be really very careful when they are drinking alcohol, especially wine.
Okay. I think one of the questions, again, we had it last time, I think is a good one. And Dr. Ennis, I think you probably could chime in on this. Do any contrast used for imaging reduce the immunity?
So I answered that earlier. My answer was that I'm not aware of any contrast agents immunologic effects. But Carol, do you have anything different to say on that?
So the question was, can you repeat the question once again? If the contrast,
any contrast used in imaging reduce the immunity system?
No, I don't think. I don't think so. I agree with my colleague that with Justin that most likely not. We are not aware of any actually interaction, and I'm not even aware of anything in the literature. So I would say no.
Perfect. My tumor came back after 2013 gamma knife surgery, and metastases were found. At that time, I was tested and no genetic mutation was found. It was decided to retest for genetics, and this time a panel was used for testing, but no mutation was found. Subsequent testing on tumor tissues resulted in a mosaic germ-like mutation on SDHB exon 4. What is a mosaic germline mutation and how many people have it?
So there's different, okay, I'll start off on this one, I guess. So there's different types of mosaicism that one has to be, I guess, when they ask this question. There's what's called gonadal mosaicism versus somatic mosaicism. So the difference being one, which is in your germline, which you can pass on from generation to generation. The other one being only in a subset of cells that are in your body and not able to be passed along. So in this particular individual, they had probably blood testing, although I can't be certain. And then they were found to not have a mutation. Then it sounds like there was probably tumor sequencing. I don't know exactly how an SDHB was looked at. That's not typical for most standard somatic tumor panels. So I'm guessing someone did some type of deep sequencing. And so then it really becomes a very complicated interpretation about whether or not that variant that was found, or this mutation was found, is meaningful or not. Typically in a tumor, when you find a mutation, you expect that the other copy of the gene was entirely lost. So if I find an individual who has a tumor where they have a mutation in SDHB and the other copy of the gene is totally normal, I would be suspicious about whether or not that variant had clinical significance or why it was being found. So, so trying to answer the question was, one, mosaicism itself is when when the cells in your body have two different types of genetic material. In this case, most of the cells are normal for SDH, but some of the cells might have an SDHB mutation. And then the secondary question in this case, what does it mean for this person? Without having the very, very detailed specifics, it's very hard to interpret. What's the frequency? We think it's extremely rare, less than 1% of our affected individuals. But I would let Carol jump in, who's probably also thought some about this complicated situation.
Oh, I think that it's very well said, and I definitely agree with that. And as mentioned by Justin, that those that they may have had, for example, some somatic defect in the tumor, it's extremely rare, especially, for the SDHB, because everything goes, to germline mutation. And of course, there is a defect in the tumor that you lose a second copy, but it's based on the germline mutation. So I would definitely agree, and we would need to have some more information what is going on, what was done, what was found, to be able to comment whether SDHB was really the player here in the pathogenesis of the tumor. Yes, there are some reports, there are very few reports, but definitely it can happen, but we would need some more information.
Okay. What can you do about building scar tissue after catastrophic surgeries? If you can speak for that.
Yeah, that's a the idea of having catastrophic surgery is not very good.
After surgeries.
I think
Yeah.
here is the best thing that we know is mobility in general. The way to avoid scar tissue is rehab and mobility, and following the advice of physical therapists. Of course, choosing your surgeon and how the surgical approach is critical to preventing. This sounds like someone who's already had a severe complication is now wondering what they can do. I think is trying to figure out mobility and how to stretch and how to loosen up whatever it is that's really adhered. And then that's where I would start. I don't know if Carol.
Yeah, I think that's it's a little bit beyond our scope, this question. So I would say to talk with the surgeons and see what can be done. You can use also hyaluronic acid and some other options that are available, and sometimes those help. But I agree, certain mobility, certain type of exercise, as well as very good intake of maybe the vitamin and some other elements. I think that would be very important. But as I said, this is a little bit beyond our expertise.
Yeah, fair enough. I think there's a little bit of a fallout from the surgical webinar. I don't have a diagnosis of Pheo Para yet, but I have a lot of the symptoms, so I believe I have it. I've been in and out of the ER for almost 2 months. Obviously, I really don't want to go to the emergency room right now. How can I determine whether I should go or not during maybe an attack?
I think the question is a little bit twisted. So I think that first of all, if you have a Pheo or if you don't have a pheochromocytoma, I think if you have a symptoms and signs that may be related to catecholamine excess, which means that you have a high blood pressure, and for example, palpitations, that the heart is beating very fast, this is maybe the reason why you are going to the emergency room, maybe on the frequent basis. So, and then you would like to know whether you have a pheochromocytoma or not. So the way how to do it, to measure plasma metanephrines, I think that will be the best, but they can measure also plasma metanephrines plus plasma catecholamines. I would not suggest to be done during the attack. It would be the best when you return from the emergency room to visit your doctor. Either, the general practitioner specialist, because they will send you anywhere to specialist, and then to measure plasma metanephrines. If you have pheochromocytoma, I guarantee you that there will be increase in metanephrines if the symptoms are related to actually catecholamines. That catecholamines may be normal in 30% of patients, but metanephrines will be positive. You also said, what should I do, or when is the situation I should go to the emergency room? That's actually individual, and everybody is dealing with high blood pressure and changes in heart rate in different way. But I would suggest that always the blood pressure over 150, 160, systolic and diastolic over 90 to 100 is always worrisome, especially in older people who, for example, have the normal blood pressure, because we know that older people, they can have a little bit higher blood pressure. And but that would be worrisome. And also if you have any symptoms like, unusual headache, nausea, vomiting, very unusual sweating, you measure heart rate and it's, for example, over 90, 100 beats per minute, that's definitely worrisome, and especially if it is lasting for a longer period of time. But everybody is different and is really individual. And of course, if you are, for example, you have some dizziness, or some patients can lose their consciousness or having other problems, it's definitely that would be very worrisome. And especially also in patients who have frequent attacks and the same symptoms and signs, they should definitely go to the emergency room.
In this case, someone who's had multiple episodes and has a high level of concern, I think they should reach out to their physician and ask that they speak with a local endocrinologist or really speak to someone who's familiar with this condition, because you have to start down the road of evaluation to get it figured out.
Okay. Again, maybe a question for a surgeon and beyond our scope for this webinar, but in an SDHV para case that is spread to bone and shows up in a PET dotatate scan through the trunk along the spine, how can you be certain the metastases along the spine are in bone versus in ganglia tissue?
Oh, that's not very complicated, because you have a very good PET scan together with CT. You know, right now and especially to very good centers and tertiary centers, universities, and some medical centers, we don't have only PET, we have a PET CT. And the CT is very important because there will be fusion image, the CT as well as PET, and then fusion image will actually show where the lesion is located. And I can tell you honestly, radiologists here, I mean, not only at the NIH, everywhere in this country are extremely good, very knowledgeable. And when they use the PET CT, they will be very, very good to tell you whether, for example, the lesion is inside the bone or is outside the bone or is touching the bone. I think that should not be a really big problem.
This individual can ask to see the pictures when they go to see their doctor if they want, and it's usually not a diagnostic dilemma. You can see spatially the distinction between inside the bone and outside of the ganglion.
Okay, it is now 6:58 according to my calendar. If either one of the doctors want to wrap up or say anything additional to our community about the coronavirus and Pheo Paras, or anything else that has come to mind over the past hour, please feel free to do that now, because otherwise I'm going to wrap this up.
No, I don't have anything to add, I think.
Dr. Pacha?
Yeah, I always say, you know, that especially those patients who have a Pheo Para ganglioma, they have a definitely abnormal function of their immune system that can be a little bit lower function, so they have to be very careful, and especially during this time. It will be better, but be careful and don't go to places where you may feel that you can get actually the virus, because you are more susceptible for the infection.
Okay, I want to thank both Dr. Annis and Dr. Pachak for your time, and just as importantly for your dedication to our patient community. I appreciate your time here, and this is the third webinar that we've had. If the community has enjoyed the webinar, we ask that you sign up for our e-news and follow us on social media. This webinar will be available in a few days on YouTube and on the website, and we will also transcribe the question and answer portion and have that available as well. If you, again, found this information to be useful and you're interested in donating, you can do so at the pheopara.org/donate website. Thank you to everybody who's attended today, and I am sending virtual germ-free hugs to all of our Pheo Para friends out there. Please stay safe and at home. Remember, we are stronger united. And again, I apologize both to Dr. Annis and also to Stephanie for coming late. I again apologize. So hopefully this has been helpful. And again, both doctors, thank you so much.
Thank you.
Thank you for having us. Thank you.